Atrial fibrillation is the commonest heart rhythm disturbance that we see in clinical practice every day. It affects about 1 to 2% of the general population. So in the UK, we're talking about over 1 million people having atrial fibrillation. When you are in atrial fibrillation, your heart is no longer beating in an organized fashion. Because in a normal heartbeat, the top part of the heart, called the atrium, and the bottom part of the heart, the ventricles, beat in sequence. When you're in atrial fibrillation, the top part of the heart, the atria, are no longer beating in a normal rate. It may be as fast as 300 beats a minute. So that drives your bottom chamber of the heart, the ventricles, which is your pump, to beat very fast and frantically. The commonest complication that we can see in atrial fibrillation is that of a stroke. AF increases stroke risk 5-fold. So it is a big unsolved clinical problem. The first treatment that we'll be thinking about is to control the heart rate. So if the AF is fast, we'll normally start some medication to try and control the heart rate to make it more acceptable and less fast. In more advanced stage of the disease, where we call it persistent AF, the atrial fibrillation is there all the time. So we need to try and do something to actually stop the AF. Quite frequently we use a procedure called cardioversion, which is electric shock, to shock the patients back to normal rhythm. These patients who are in a more advanced stage of the condition, persistent AF, even if the cardioversion is successful, quite often they flip back into AF. So we need to do something more definitive. So over the years, a procedure called catheter ablation has been developed. In the early stage of the condition, persistent atrial fibrillation, catheter ablation is actually quite effective. But in patients in a more advanced stage of the condition, just burning the pulmonary veins are not enough. A standard AF ablation procedure involves us putting catheters in the heart, both mapping catheters and ablation catheters. These are the catheters we use to burn the different tissues in the heart. We use a keyhole procedure, so we normally gain access from the groin, and then we pass the catheters up from the groin area into the heart. And we'll place these catheters in strategic areas in the heart to begin with, to then collect the electrical signals. Then we can export these signals into the new system, which is the Doppler console, and use clever mathematics to process these signals and generate a rotor map and identify the eye of the storm. So the eye of the storm is believed to be the important critical circuits which is generating the problem in persistent atrial fibrillation. So using this new software, we can generate a map that allows us to localize the eye of the storm, and therefore we'll be able to burn less and achieve more. So we are hoping that the procedures will be shorter and the procedure success will be better than what we currently do with contemporary techniques. We do a lot of research at the University of Leicester on all sorts of heart rhythm disturbances. AF being a major clinical problem, obviously we have spent a lot of effort in advancing the knowledge and also designing new areas of treatment. Persistent AF is a more advanced form of the disease, and admittedly we still haven't quite cracked the problem. So we would like to understand the rhythm more, and we have certainly spent a lot of effort over the last 5 to 10 years in doing mapping studies, studying various patients with different morbidities to understand this rhythm more. So adding the Doppler into our technologies will certainly help us go a long way in advancing our knowledge, and also to test various hypotheses whether truly burning in these critical areas will lead to better outcome.